Great. Welcome back to Healthcare. Since we're waiting on our other legislative council, we're going to switch gears and go to H206. So if you remember, this was the DEVA housekeeping bill that we passed out of here, is now coming back to us from the Senate, or not yet. It's still on the floor, right over there. But there's quite a few additions to it. So I thought it best to walk through it. If we're comfortable, we'll do a straw vote today so that when it gets here, we'll be ready. And if we're not comfortable, we can come back to it. I'm going to turn it over to Legislative Council. We're going to switch gears. I'm sorry. Oh, can you just stay right there?
Yes.
And we're going to, Katie just joined the Zoom. We have one quick question for her on 473. And then we won't vote on that yet, but we can let Katie go on her way. Okay. Thank you. Hi, she joined. All those paying attention, I'm sorry, we are jumping back and forth. I'm sorry, 47.
Yeah.
Katie, are you there? Hi.
Hi, how are you?
Good, sorry. This should not take long, I hope, although I always say that and it does. We have one thing we want to add to 47, and then one we have a question on.
Okay, let me grab a notebook. Hang on. Okay,
All right, and if you can just introduce yourself for the record.
Katie McLean, Office of Legislative Counsel.
Thanks. So in the report, we want to add Vermont Psychiatric
Survivors.
Survivors. Thank you.
Survivors.
Okay,
And then we had a question about potentially adding one word. And so it is in section B1.
in 7505.
Yeah. Yes.
Okay, I have to pull it up. I'm not.
Okay, that's fine.
I'm in the Senate courtroom.
Okay.
Let me,
Thank you for being flexible.
yeah, no problem. Let me just pull up the draft. So I'm looking at the same thing you're looking at. Okay, I have my draft pulled up. Go ahead.
Okay, so if you're on row 5, the beginning of the sentence there says the law enforcement officer or mental health professional shall apply to the court for the warrant without delay while the person is in temporary custody.
Mm-hmm.
The suggestion is to start the next sentence, we say, then the law. No, that's not where we are. Okay, sorry, go ahead.
Line 8.
Line 8, between may and transport.
Oh, okay.
Would put the word then. Does that make sense?
So the law enforcement officer or mental health professional, if clinically appropriate, may then transport the person.
Sure.
Is that, I mean, that doesn't change the intent, right, of the language. It just kind of tells you the progression of when things are happening.
I think it's just giving us a timeline.
Okay.
May then transport. Yeah, I think that's okay.
Okay. Great.
I'll draft that up and I'll send it back over to you.
That would be excellent. Thank you.
Okay. No
Wonderful.
problem.
Okay, thanks.
Yep, bye.
Okay. So we're going to go back to 206 and we'll come back to 47. Sorry to switch all that around, but we have to take legislative counsel when we can get them. All right. Ameren.
For the record, Ameren Abergele Legislative Council. So I'm going to share my screen so you are able to see H206 as passed by House, an act relating to miscellaneous changes affecting the duties of the Department of Vermont Health Access. So I'm just going to briefly cover what was passed out by this body before we move over into the Senate amendment or proposal of amendment. So the first section, you might recall, this is concerning Medicaid coverage for adult dental services, specifically around diagnostic, restorative, and endodontic procedures. There's the maximum of $1,000 per calendar year, except that the Department of Vermont Health Access may approve expenditures in excess of that amount when exceptional medical circumstances so require. And then in this new language, we're specifying that exceptional medical circumstances include emergency dental services. And then in subdivision B, there are certain individuals who are not subject to that annual maximum benefit amount of $1,000, which are individuals served through the Community Rehabilitation and Treatment and Developmental Disability Services programs, and then Medicaid beneficiaries who are pregnant or in the postpartum eligibility period. So that's the first section, right? The second section concerns circumstances where a Medicaid beneficiary also has other third-party insurance, and Medicaid is going to seek reimbursement from that third-party insurer. The changes in Section 2 to Section 1908 and 1909 in Title 33 are to specify that if the insurer requires a prior authorization for coverage of services, that the agency, in this case, the Agency of Human Services, authorization that the item or service is covered under the Medicaid state plan or waiver is sufficient to cover that requirement of the third-party insurer that there's a prior authorization. So it means the third-party insurer cannot deny or cannot refuse to reimburse Medicaid because there was no prior authorization. So that is the second section. The third section is concerning the Vermont prescription monitoring system. You may recall there's a certain set number of people that are able to access the Vermont prescription monitoring system. The change in subdivision C would add a new person that's able to access the system, and that is a designee of the medical director of the Department of Vermont Health Access. Presently, it's just the medical director. This would add one additional person being having the authority to access the prescription monitoring system.
Does that mean one person, or does that mean at any given time they can designate a person?
Anytime they can designate the person.
Okay, so it gives them flexibility.
Yes.
Okay, great.
And now Section 4, I'm going to go over, and then we're going to switch over to the Senate proposal of amendment because they are proposing to change Section 4. So Section 4, as passed out by the House, is a report requirement. This also requires the Department of Vermont Health Access to collaborate with representatives of Vermont's federally qualified health centers to develop a mutually agreeable alternative payment methodology for Medicaid payments to the FQHCs. And then the report would be due back, or a progress report would be due back on or before December 15th, 2023 to this committee and the Senate Committee on Health and Welfare. Okay, so now I'm going to switch over to.
Yes.
Okay.
I wanted to make sure I wasn't distracting you because I'm distractible. So, no, I can't remember what I was going to ask. No, I did. The federally qualified health centers, I know I've been here 7 years. That's like the community health center, for example.
Yes.
Okay, just wanted to make sure so this will help with the issue that they've been facing about payment.
Yes.
All right.
And there's an amendment, so.
Oh, okay.
So now you can see, hopefully, yes.
So I see the line. Okay.
The proposed amendment that is on the Senate notice calendar for today, it will be up for second reading tomorrow. This is actually a substitute amendment for the Senate Health and Welfare's original report that passed out of committee last week. But this is what the Senate will be reviewing tomorrow.
The full Senate.
Yes. So the first proposal of amendment is to strike out Section 4 that I just went over and replace it with this new language that you see on page 1. It is very similar to what I just went over with some changes. So it still requires DVA to collaborate with representatives of the FQHCs to develop a mutually agreeable alternative payment methodology for Medicaid payments to the FQHCs. But it then specifies that the methodology must be at least equal to the amount that would be paid under the prospective payment system established under the Benefits Improvement and Protection Act of 2000. And then additionally, the date of a report back is now October 1st, 2023, rather than December 15th. And there is a new destination for the report. So it is also going to the Joint Fiscal Committee
And that's pretty standard when we have reports coming back in.
during the non-sessions. Yep.
On session. Yep. Any questions, Go, Brian?
Do you know why they added that Easton around at least equal to the amount from the year 2000, which is 23 years ago? Is it because there was a risk of it being lower for some reason, or?
The language that you see here was language that was brought to the committee by State Primary Care and DIVA, who collaborated on language.
And geez, it's amazing that they are both in the room with us today.
Yes. So I think you could hear more if you so wish
I
about
would
it.
like to when they're ready.
Okay, let's maybe keep going through the
Yeah.
language and then we'll come back.
And then the second instance of amendment would be striking out the effective date section and then adding 5 new sections, sections 5 through 9. So the first, section 5, Blueprint for Health Payments to Patient-Centered Medical Homes Report. So on or before January 15th, 2024, the Director of Healthcare Reform at AHS shall recommend to this committee and Appropriations and the Senate Committee on Health and Welfare and on Finance the amounts by which health insurers and Vermont Medicaid should increase the amount of the per person per month payments they make to Blueprint for Health patient-centered medical homes in furtherance of the goal of providing the additional resources necessary for delivery of comprehensive primary care services to Vermonters and in order to sustain access to primary care services in Vermont. The agency shall provide an estimate of the state funding that would be needed to support the increase for Medicaid, both with and without federal financial participation. The agency shall also evaluate and report on potential mechanisms for ensuring that all payers are contributing equitably to the Blueprint on behalf of their covered lives in Vermont, including a consideration of supporting Blueprint initiatives through the healthcare claims tax established in Title 32.
So this language came from our budget, if I remember correctly. So this committee put this language into our recommendation to House Appropriations. It was taken out of the Senate budget because they put it in here instead. So this is language we ultimately wanted from the beginning.
It came out of the budget.
Yes, and put it in here. Why, I don't know, but it did.
I mean, it's this, I wonder, I'm not saying why, but I could see why you might do it, because this is like studying payment. It's not necessarily appropriating the money now. And even though it's related to the appropriations of the state, they might have felt fit better here. But
Yeah, but it's language we wanted, so,
yeah.
okay.
The next section would be a repeal of the prospective repeal of 18 VSA 9473G. So this is a repeal of a repeal. Presently, not to make things confusing.
We're used to it in this committee. It's okay.
Does that mean it cancels itself out, rips space time?
So presently,
It's in,
eight,
right?
so presently, yes. So currently 18 VSA 9473G is scheduled to be repealed on April 1st, 2024. And this section says, a pharmacy benefit manager shall not, 1, require a claim for a drug to include a modifier or supplemental transmission or both to indicate that the drug is a 340B drug unless the claim is for payment directly or indirectly by Medicaid, or 2, restrict access to a pharmacy network or adjust reimbursement rates based on a pharmacy's participation in a 340B contract pharmacy arrangement. So that those prohibitions are currently in statute.
But to be repealed in 24.
But to be repealed in 2024. If this section does not pass, those prohibitions will be repealed in a year.
And so this is saying, remove the repeal and keep it permanently in statute.
Permanently in statute.
So that's the word permanently. I was wondering about that. Permanently in statute. Making permanent in statute, I was just wondering, it makes it permanent in statute, makes it, I remember.
It's hard to say. it eliminates the repeal so that the language remains, I would say it remains in statute.
Okay, that's great. Thank you.
Nothing is truly permanent.
Okay, that's what I was wondering.
Does it repeal a sunset?
It repeals a sunset is another way of saying it.
Sunset.
But repeal is more fun.
Especially this time of year.
As opposed to the sunset sunsetting?
Okay, let's keep going. So we can come back to it, but let's
Back to another, I'm sorry, I just have a question on, back to Blueprint, if I may. When it says payers, each payer, do we know who those are? Does that include Medicaid? Does that,
Yes, so that would be Medicaid, Medicare, commercial insurance.
okay,
everyone that pays.
Everyone
everyone,
that
so, but not
pays.
Medicare. Medicare, I don't know if that would be applicable. Anyone?
No, it would be Medicare.
Okay, the word.
Yeah, and if you go back to the blueprint presentation we had, you can see all the, like, yeah. You good, Leslie? Okay, so 7.
So switching gears, we're now going to look at the hospital lien statute. So for context, we are looking at the situation where an individual is injured in an accident, say a 2-car accident, and goes to the hospital, receives services, and has a large medical bill. Presently, under Title 18, Section 225, the hospital is able to file a lien upon any monetary award that that patient gets if they were to, for example, file a lawsuit against the other driver, and then at some point down the line, receive money as part of a settlement or judgment. So presently, as you see in Section 2251, there are exceptions, such as the lien would not be possible if the accident were part of workers' compensation claims. But otherwise, the hospital can attach a lien up to $500 or 1/3 of the recovery, whichever is less of the patient's monetary recovery. So if you think of the patient's recovery as a large pot of money, first, under the current language that you see removed here in lines 10 to 12, you'll see that the lien is subordinate to an attorney's lien. So first, attorney's fees come out. And then under current law, the hospital can attach all the way up to $500 of what's remaining, or 1/3 of what's remaining, whichever is less. So that is present law. The new language here in subsection B says that notwithstanding the hospital lien process in subsection A hospital shall not have a lien under this chapter if the patient has health insurance, in this instance, including coverage under Medicare, Medicaid, or a health plan issued by a health insurer, as defined in section 9402 of this title, and the patient or the patient's heirs or personal representatives, in the case of the patient's death, provides the hospital with proof of health insurance not later than 90 days after the patient's discharge from or death at the hospital. So we're really limiting the circumstances here of when a hospital would be able to pursue a lien on that patient's monetary award. There is an exception here in subdivision 2. So notwithstanding subdivision 1, the hospital may file a lien for any amount owed to the hospital for the patient's deductible or co-insurance, or both, under the health insurance plan for the medical or other services furnished by the hospital by filing a notice of lien at least 120 days after the hospital billed the patient's health insurance plan for the amount owed to the hospital for those services. So the hospital, if the person has health insurance, would go to the health insurance plan first and, for coverage of the claims. And then if the patient has not paid their deductible or co-insurance amount, the hospital could still then file a lien just for that patient's portion of the cost share. There's a lot in here, so I'm going to go
Yeah, I'm gonna wait.
slow.
Hold on, Alyssa.
I was gonna wait.
Would the patient have already filed? I guess I'm thinking about the timeframes.
and that these seem quick. What if the person hasn't filed like a settlement or something yet? Or, I mean, this is all if the person essentially is suing for damages. What if the patient has not yet sued for damages? How can the hospital then file a lien against something that hasn't happened yet? And then what happens when the time runs out? So,
So the, trying to think if it makes sense to go over the rest of the lien statute for you. In terms,
Let's go over the rest, because I think we're going to have some maybe potential testimony on this.
testimony will help you a great deal there in terms of seeing logistically how this plays out in real life. I will say that this current process doesn't change that aspect of the timing of what the hospital, in terms of when a hospital can file a lien. No, I take it back. Okay.
isn't this all new language?
This is new language, yes. Yes. So right now you don't, I'm going to wait. Okay.
Yeah,
I'm going to wait.
that's fine. Keep your questions and we'll come back to this section.
So subdivision 3 specifies, so now we're looking at in the case where the hospital is seeking payment from the insurance plan. This says that the patient's health insurance plan shall not deny payment for services furnished by the hospital to the patient on the basis that some or all of the patient's medical costs may be covered by a property and casualty insurance plan, unless such denial is required or expressly permitted by state or federal law. When we're talking about property and casualty insurance plan, we're talking about, for example, the person's auto insurance, if they may have a component of their coverage that covers medical costs in case of an accident. So it's saying that the health insurance plan can't refuse to pay the claim to the hospital because that patient might have other coverage, unless under law that insurance plan has the ability, already has the authority to do so, to deny that payment.
It's just like when you go into the hospital and they're like, so is this as a result of an accident? This is why they asked that question.
Those kinds of questions, also trying to get at whether it's a workers' compensation claim,
Okay,
who they should be billing for your insurance.
right.
Just to comment on that, as I've been thinking about this, it means that the hospital doesn't have to honor the contracts of the insurance company so that they can charge the car insurance company full rate, as opposed to the contracted rate with the insurance companies, as it stands now. Does that make sense? This is what I'm learning.
And again?
So as it stands now, am I close?
I know, just listening.
Okay. So as it stands now, my understanding is that if you go in for a motor vehicle accident and they have an opportunity to have access to your car insurance settlement, they can charge full rate.
The hospital.
The hospital can.
Not what the hospital.
They have to charge your insurance. They have to charge the contracted rate, which would be considerably lower.
Gotcha. Yep.
Just this part, the expressly permitted by state or federal law, I'm just trying to get it. Are we basically saying in this section that health insurance plans no longer can deny hospital claims because there might be a third-party liability?
In this circumstance, yes. But we're leaving in the unless denial is required or expressly permitted under current law.
Okay, that was so under current law.
There are circumstances, yes, where the insurer could say you need to go to so-and-so first.
Okay.
Subsection C, now we're getting into the attorney's fees as part of the lawsuit. So under current law, as we saw previously, once you have this pot of money, the attorney's fees are taken out initially before the hospital can pursue the rest of the monetary reward for their services cost. In subsection C, the new language would say that a hospital that recovers under this chapter shall be responsible for a pro rata share of the legal and administrative expenses incurred in obtaining the judgment, settlement, or compromise. So the attorney's fees, in terms of calculating what the hospital is able to attach a lien on, the attorney's fees are still taken out first. But if, for example, in that remaining pot of money, the hospital can file a lien up to, say, a third of what's remaining, they would then also they would be responsible for paying a third of the attorney's fees. So presently, the hospital is not responsible for paying any portion of the attorney's fees, even if they benefit from the lawsuit being filed and recovering through the lawsuit.
And since this is clear as mud, we will have some testimony on this.
It's hard, really hard.
It is hard.
I've been working on this for days.
Yeah.
And then in subdivision 2, you may recall that under current law, the hospital can attach a lien on all the way up to $500 of what's left in that pot of money. The new language here would cap that hospital lien amount, but it does not exceed 1/3 of the net judgment, settlement, or compromise received by the injured patient. So presently, they can go all the way up to $500 of what is left after the attorney's fees are taken out. But under this new, under the new language, after the attorney's fees are taken out, they can only take up to 1/3 of what remains in that pot of money.
I apologize for having to step out. So I need some clarification on who the lien would be placed on. Is it on another insurance company, or is it on the patient if they received damages?
It goes through the courts. The lien is placed as part of the lawsuit, and so it's paid directly through whoever is responsible for, who's financially responsible for paying the reward.
It could be.
Right. It could be, well, it wouldn't be the patient.
Okay.
Because they're the injured party.
Okay.
Oh, well, that's a total mystery to me. I thought it was the patient.
It is, in a sense, coming, so if this did not exist, if this statute did not exist, if you did not have, let me back up, I lost my train of thought.
E1 says.
So currently, I'm sorry, what was the question?
Wondering about.
Oh, yes.
But the patient is the one that gets the award.
Right. So normally, you think of it as being the money all going to the patient, the injured party. But really what happens is that during the court proceeding, the money is sort of theoretical money while all of the lawsuit is happening. And then money is taken out and apportioned to who it is supposed to go to according to the order that happens in statute, right? So the attorney's fees would get paid to the attorneys. And then, so it's not, aren't taking money from a patient who has already received the money. It's just money is being withheld from the reward that goes to the patient.
Their damages.
Yeah, right.
How's that different from what happens right now?
That part is not different.
Okay.
That currently happens. The difference here is that you're limiting how much the hospital can receive.
Plus, so, I mean, I'm assuming right now that most settlements are based upon things like attorneys, how much are your attorney's fees, how much are your hospital fees, pain and suffering, that sort of thing. So if we're limiting that the hospital can only be 1/3 of the whole of the net settlement, aren't we basically jacking up? So if the settlement is going to include all of the hospital fees, then you're tripling the judgment regardless Isn't that sort of what you're doing?
If this, if the new language becomes law, then the hospitals would receive less. So in theory, the injured patient would receive more unless there are other parties that also have liens for some reason and are entitled to some of the reward. But yes, you are shifting where the money can go.
But aren't you influencing the settlement?
It's possible that as part of the settlement negotiations, the fact that the hospital could only receive a third would impact how the parties negotiate. But I would not say that you are automatically increasing the total settlement. You're just changing how the pie is sliced.
And I would say, let's hold that question for 1 minute. So folks in. Okay, I'm just looking at the time and we've got to get to 473. So we're going to keep going.
All right. So that's the end of section 7. So we can move on from hospital.
So we want to start getting easier.
So next, section 8 would add a new section to Act 167 of 2022. This is concerning the transformation planning with hospitals. So the new language would say, subsection A, the Agency of Human Services shall engage in transformation planning with up to 4 hospitals or other number of hospitals, if possible, with alternate funds to reduce inefficiencies, lower costs, improve population health outcomes, reduce health inequities, and increase access to essential services while maintaining sufficient capacity for emergency management. The transformation planning shall be informed by the data analysis and community engagement required in Section 2 of this Act. The Secretary of Human Services or designee and the chair and staff of the Green Mountain Care Board shall consult with each other on the engagements in this section and the data analysis and community engagement required in Section 2 of this Act to ensure the work is aligned. Then subsection B, on or before February 15th, 2024, the Agency of Human Services shall update the Senate Committee on Health and Welfare and the House Committee on Healthcare on the progress of this work.
And if you remember, what came about because of a conversation that Senator Lyons and I had with Green Mountain Care Board Chair and the Secretary of AHS that originally went into the budget. I updated everyone that Act 167, when we put it in place, it was to do community engagement. We had taken the transformation planning out of it, but then AHS came forward and said, we have some hospitals who might be ready for transformation planning. And so we wanted to ensure we amend 167 to allow that to happen. So that's what this does.
Okay.
It was in the budget language, it was pulled out and put into here.
All right, so this is to abet what we did last year.
And allows some hospitals to start transformation, yeah. So thank you, Ameren. So I will say real quick, we have, hold on, Leslie. So we have Mary Kate from Bi-State here, and I know there was some questions on section 4. So let's get those out of the way so we don't have to have Mary Kate come back. So Brian, I think it was your question. I forget whose question it was, about why the language has changed and why it's just specifically referencing this Benefits Improvement and Protection Act of 2000. Do you mind?
Sure, not a problem. For the record, Mary Kate Malden, Bi-State Primary Care Association. Really the thrust behind the change of the language was to clarify that the alternative payment methodology that we're talking about is the alternative payment methodology identified in BIPA, the Benefits Improvement and Protection Act. And under federal statute, payments under that system, under that methodology, has to be at or greater than what would be paid through the prospective payment system, which is what BIPA lays out as basically that bare minimum that states can pay federally qualified health centers.
Does that help everyone?
Is it, I might have missed it when you were saying it, just because of processing issues, but like, is the minimum determined by a formula or is it like a number?
It's, yeah.
We're not going in the weeds.
Quickly, but yes, it does. So BIPA does lay out what that prospective payment should be. And it's a methodology that determines that based.
Okay, that's what I was getting at. It's a methodology, it's not like a number, it's a methodology to determine the number.
Yeah, and it's based on each individual health center's costs.
Great.
Yep.
So it looks at their spending and then determines what a fair amount is to sustain that.
Sort of, we can get through this, if you want to talk more.
We don't need to get too detailed. As long as, I just wanted to generally understand why a decision made in 2020 would still be good today. But if it's because it's based on a formula, that still makes sense.
Yeah, it is based on.
Thank you.
Actually, that was kind of my question. Why wait 23 years to ask for this to be?
Again, you're asking a question that like one scratch under the surface gets very technical.
Whoa.
Peter, hopefully I'm getting getting ready to be your next witness. I felt like it's going to be like.
All right.
So
I don't expect to be asked about it, but I just was worried about it in that we're all asking about it. So
Oh, you're the reporter.
Yeah.
I'll have someone ask you about it.
I knew you would. See, that's why I had to prepare for him.
So is there an easy answer? If not, you can take it offline with Leslie.
Yeah. You can just email me. Don't worry about it.
Yeah, but I mean, basically we, like, FQHCs are hurting right now and we are losing other funding sources. And so we can no longer subsidize the Medicaid provided services. So that is part of why we are in this collaboration with DIVA, is to address some of these concerns and issues. And that was the thrust behind including this language in this bill.
So there was a recent, if I may, a recent change in your funding streams that requires you to look for other ways?
Not quite. I mean, you think of like the different funding that F2HCs get. There's the grant, and that is really to support the care that's provided to the uninsured, and the underinsured are sliding fee scale financial assistance services. Then there's the savings we get through the 340B program, which is the repeal that Amber talked about, repeal of repeal. And those savings are eroding very rapidly because of steps taken by manufacturers and PBMs. Again, very complicated situation, but without those, FQHCs can no longer subsidize the care they provide to Medicaid without the sufficient reimbursement.
Daisy, did you have a question?
I did. Is that reference to the 2020 policy just sort of a guardrail so that if, as you go into the APM, it doesn't provide as much financing, it will sort of protect you from?
I mean, that's federal law that we need to have at least the PPS and then an APM, the alternative payment methodology. I want to be really clear that that is a term that is used in BIPA. And that has to be at least and can be greater than the PPS. So it's basically there's the prescription for the PPS and then the state Medicaid in collaboration and agreement with each FQHC can pursue this alternative payment methodology that can change that payment methodology, that payment calculation. But it has to be at least, under federal law, it has to be at least that PPS rate.
And so I don't want to go too in the weeds on because it's not coming, we're not like saying you have to do it. We're saying they need to collaborate. So
I was just curious about section 7, is specific, like, reasoning behind it is because people are getting less in their, with the liens.
can we hold on the liens?
Okay, sorry.
We're gonna have testimony on the liens.
Okay.
Let's hold on that. So, section 4.
Just a quick, I'd love to talk with you offline too with Leslie about, especially the PBM part.
Oh yeah, absolutely.
Okay.
And Ginger's here. Ginger, is Diva okay with this language?
Yeah, Ginger Irish, Department of Vermont Health Access, we are fine with this language.
Okay. Great. Marie, you can't go very far.
I'm right outside the door.
Okay. Okay, so that's section 4. Section 5 is the blueprint, which we had already recommended. Section 6 is the repeal of the repeal. Section 7 will have people come in tomorrow and understand the liens process. And then section 8 is what had been put into the budget. And again, it's just allowing transformation to happen.
Can I ask one more question? This is about effective date, just to get an answer on why January 1st for the lien section.
Probably has to do.
I'm trying to recall.
calendar year of insurance plans?
The first thought that comes to mind, but I'm.
And so let's ask that of the lean people when they come, which is here, but we're not doing it because we got to switch to 473. So let's talk after. Thank you. So thank you, everyone. So we're going to have to come back to this. We have a little bit of time, not much, because it's still on the Senate floor. So we'll look to have testimony tomorrow after the 10 a.m. floor session on the lien section. Okay. All right, so now we're switching to 473, which is the radiologist bill that has come. It came back to us. If you remember, Jen came and talked to us about the amendment that the Senate had made, which then we had questions about what does it mean to be a Vermont facility or not a Vermont facility. So Jen went back and worked on some language. So my intent is that we review this, we vote on it, and I present it on the floor at 3. That's what we're doing. Or we're not presenting it because we don't agree to vote on it. That's always an option. So Jen, I'm going to turn it over to you, and I think it's posted.
Yes, I believe it is. Jen Carvey, Legislative Counsel. Now you all know I'm on Zoom because of my helpful unmuting. So I will put my language up on the screen and we will walk through it. It's H473. I don't know.
Potent amendment.
Potent amendment.
Yeah, well,
Yes,
so,
because it's the, as you may recall, it is on the calendar. The bill is on the, as it came over from the Senate, is on the calendar. So it's not in this committee. So you committee cannot amend it unless you had it referred here. So this would have the chair move that the House concur in the Senate proposal of amendment with further proposal of amendment by doing a strike all, which is just the way the language works. So this amendment does two things. I want to stop, pause, and just build a little bit on what the chair was saying. When we had looked at the language around where the primary work site and employment location or employment for the primary supervising radiologist and radiologist assistant was, and the language said they have to have as their primary work site the same Vermont healthcare facility or an affiliate of the facility, and we talked about that. So I addressed that in here, but we also talked about the radiologist who's doing the supervising and whether they had to be licensed in Vermont or whether they could just work at Dartmouth-Hitchcock or a hospital in Plattsburgh or something like that. And I said the language in the definition is kind of unclear. So I addressed that too. So that's where we're starting here in section 1. We're going in, this is all highlighted in yellow because it's new to the bill, but anything that isn't underlined or struck through is existing law. And I had worked on this with the Medical Society, UVM Medical Center, and the Board of Medical Practice, and they all said this language worked. So this would specify that a radiologist is a person who is licensed to practice medicine or osteopathy under Chapter 23 or 33 of this title. That means they have to be licensed in Vermont and who meets one or both of the following requirements. They're certified by or eligible for certification by the American Board of Radiology or the American Osteopathic Board of Radiology or their predecessors or successors, or the person is credentialed by a hospital to practice radiology and engages in the practice of radiology at that hospital full time. So in the existing statute, it said radiologist means someone who is licensed to practice under Vermont law and who is certified by or eligible for certification or who is credentialed. And it was unclear where what the and the or each applied to. So now we're being clear. Everybody who's a radiologist under this chapter who qualifies to be a supervising radiologist means somebody who is licensed in Vermont. And then they have to meet at least one of those other qualifications. They're certified or eligible for certification, or they're credentialed by a hospital to practice radiology and do so full time.
Yep.
So this means the supervising radiologist.
Yes, this means everywhere in this chapter that the word radiologist is used, it means this definition. And so for our purposes, it's really about the supervising radiologist or another radiologist. I think there's reference at one point to a radiologist. So yes, if we're saying radiologist in here, we're always meaning a Vermont licensed radiologist who is certified or who works at a hospital full-time doing radiology, or both. So it's not really changing, as I understand it, not really changing how the Board of Medical Practice has been interpreting the definition, but the language was not clear to the average reader, and so we are clarifying here. So this section, the change here in section 1, subdivision 6, is not a change in the law, at least as the law is being implemented. It is a change in the way the law is written to make it clearer what the interpretation has been.
And one more question. Does it affect somebody, because it says full-time here, does it affect somebody that might be on per diem?
This, under existing law, it's a person who is credentialed by a hospital to practice radiology and engages in the practice of radiology at that hospital full-time. So I guess perhaps I would turn to our professionals to understand how per diem works and whether you could be considered practicing at a hospital full-time on per diem pay. Can I phone a friend on the committee?
Yes. So technically speaking, you could work full-time, work full-time as per diem, meaning you would get to choose what days you worked. I've worked per diem before and worked more frequently than my full-time colleagues. Being per diem means that you don't get benefits. There are other things you give up so that you get higher pay and you get to choose your schedule.
So that's really a work arrangement. Per diem is sort of how you are employed by the hospital, but you can be employed sort of the equivalent of full-time.
So the problem is I would say most are not like me who might work a lot of hours. And the concern, I think, is around maintaining skill and education. Some per diem people might only work a few times a year, and it's hard to maintain your practice and your skills if you're only working a small amount.
So it sounds like then under current law and not changed by this, it really has to be somebody who is practicing radiology at the hospital full-time, regardless of whether their pay arrangement involves, benefits, but it would be what would be considered full-time is what is required. So I think it doesn't preclude a per diem person if their work arrangement is the equivalent of or is full-time, but it sounds like for most people who are working per diem, that's not how they're working. So as I said, the way radiologist is used throughout this chapter is really about having a supervising radiologist available for intervention and consultation. And so the existing law requires that person to be practicing full-time or be certified. So you could
One or the other.
One or the other, or both.
Okay.
And again, that's all current law. I'm just making it easier to read and understand.
And I just have one question more about this now. What if that person, let's say, is working at UVM Medical Center, that's the hospital, and then all of a sudden there's a shortage of people, and this person has to go to Albany or has to go to some other hospital?
I think this is a question for the Board of Medical Practice. I can't tell you how they would interpret this. This is, again, about supervising radiologists. If they're the primary supervising radiologist, I suppose that could be, although it's still in the same network or same affiliate. So I don't, off the top of my head, it doesn't seem like it would change anything as long as that person continues to be licensed to practice medicine in this state and is either certified or is credentialed by a hospital to practice and engages in that practice full time.
I just don't want somebody who's being supervised by this person to get in trouble.
I don't think that's how this, or I mean, if the primary supervising radiologist leaves, moves away and works at a hospital in another state that's not affiliated with a hospital in Vermont, then the radiologist assistant needs a new primary supervising radiologist. I think that's I think that's how it works now and how it would continue to work.
Okay.
Okay. So the other change that I made is really the one to address the issue that we had talked about, which is about the primary supervising radiologist and radiologist assistant being employed by and having at their primary work site the same, I'm taking out Vermont, same healthcare facility or an affiliate of the facility, provided that the radiologist assistant's primary work site shall be located in Vermont. And then keeping that same language about the primary supervising radiologist not needing to be physically present as long as they at the same location, as long as a supervising radiologist is readily available for consultation and intervention. So the changes made by this provision are taking out the requirement that it be a smart healthcare facility, recognizing that you wanted to make that expand the ability. And the Senate had as well. I talked to the chair about it this morning and she said, I remember asking that question. And I said, yes, but we talked about it more and then I realized it didn't work. So it was a little last minute down there. So the same healthcare facility or an affiliated facility, but it's really the important piece here is that the radiologist assistant's primary work site is here.
All right. Is everyone good?
That's it for this changes.
So they can be supervised from afar as long as they're connected to a affiliate of a facility, but their primary work site has to be here.
Radiologist assistants here, yes.
Okay. All right. Anyone have any questions? Guess we take an actual vote. Vote or straw vote?
I think it's a straw vote because you're,
Okay.
because it's an amendment from you. It's not an amendment from the committee.
Great. Okay.
Take out the highlight.
And then let's get to vote. So all the,
Well, we could note to make an amendment from the committee.
right, we don't have a lot of time.
But then we would just have a regular vote.
34 minutes. So all those in favor of supporting this amendment? We are 10-1-0. Okay. Oh, I'm sorry. Thank you, Brian. I looked everywhere but on the screen. All right, so it's unanimous. Okay. So, all right, okay, we need to stay focused. So I need to get this to the clerks.
Yep, you need me to take out the highlighting, which I'm doing right now. And then I will email it to you and you can email it to the clerk's office.
Okay, great. So while she's doing that, are people comfortable with going back to 47 and voting?
Yes.
Okay. Are you ready?
Do we need any more discussion?
Does anyone have any more to discuss on S47? Would someone like to make a motion?
I move we approve the bill.
Okay. Alan's the second?
Right, and we are on draft 8.1.
Yes.
Yes. Great.
Okay.
Representative Rebecca.
Yes.
Representative Carpenter.
Yes.
Representative Chena.
I'm coming back in a second.
Yeah.
Representative,
Oh, no, we can't, right? We're not doing straw vote. Okay, go ahead.
Representative Cordes. Yes. Representative DeMar.
Yes.
Representative Farlise Rubio.
Yes.
Representative Goldman.
Yes.
Representative Peterson.
Yes.
Representative Black.
Yes.
Representative McFawn.
Yes.
Representative Houghton.
Yes.
Representative Chena.
Yes.
The motion passes 11-0-0.
Great. Thank you, everyone. I know that was a,
Lori, this is a strike all, correct?
yes. Strike off. Yes.
That's 47.
Yes. Yes. Okay, so we will have 473 on the floor in 30 minutes. We'll be done for the day in committee and we will see you back here at 9 o'clock tomorrow morning.